Blood tests, which are done in the cases of major or minor hemorrhage, that are complete blood count and coagulation profile, 4 units of blood cross match, urea electrolytes, LFTs, if the woman is having a blood loss and the initial hemoglobin level does not reflect the amount of blood loss. So it is rarely used, and clinical judgment should be used for deciding and calculating the amount of blood loss. In those women who have low platelet count, then in cases of severe absorption and associated coagulopathy, there occurs the consumptive coagulopathy and the platelet count is decline. In cases of minor hemorrhage, a full blood count and group and phase should be performed, and the coagulation screen is not indicated unless the platelet count is abnormal. In women who are rhesus negative, Lahore test should be performed to quantify the fetal maternal hemorrhage to gauge the dose of antidote required. Ultrasound scan should be performed to confirm or exclude placenta previa if placenta previa is not placental localization is not already known. Ultrasound scanning is well established in determining placental location and diagnosis of the placenta previa. Those women who have been assessed for the fetal heart rate, a cardiotocograph should be used if mother is stable and resuscitation has commenced to aid decision about the mode of delivery. Whenever possible, CTG monitoring should be performed where the knowledge of future conditions will include the timing and mode of delivery. Ultrasound should be uh, carried out to establish fetal heart rate pulsations if fetal viability cannot be detected using external auscultation. In the context of suspected vasophilia, various tests exist that can differentiate between fetal and maternal blood and are not often not applicable should women with APH be hospitalized. If so, for how long? Those women presenting with no longer bleeding and where placenta previa has been excluded, they can go home after reassuring initial clinical assessment. And those women who have APH heavier than 14 and women with ongoing bleeding should remain in the hospital at least until the bleeding has stopped. And those who have individual assessment and sound clinical assessment and they are low risk, they can be discharged. Should corticosteroids be administered on women who are presenting with APH before term? A single course of antenatal corticosteroid to the woman between 24 and 34 weeks of gestation at risk of preterm birth should be considered. And in women presenting with spotting, where the most likely cause is the lower ventral tract bleeding, where imminent immediacy is unlikely, corticosteroids are unlikely to be of benefit but still could be initiated, considered. Women with nitrogenic spontaneous preterm birth up to 34 plus 6 weeks of gestation should receive congenital corticosteroids. And anticorticosteroids, they are associated with significant reduction in the rates of maternal death and respiratory distress syndrome and interventricular hemorrhage. the ventricular hemorrhage, respiratory distress syndrome, and the neonatal death, rates of neonatal death. Supracholetic therapy should be given to the women presenting with APS who have declined activity. Supracholetic should not be considered to delay delivery in a woman presenting with major hemorrhage or who is hemodynamically unstable or there is evidence of fetal compromise. So, courses should not be given in such circumstances. And senior obstetrician-led decision should be used in initiation of the dialysis in events of an APH. And those women who are benefiting from the tocolytic drug are those who have very preterm and those needing transfer to a hospital from one setup to another where neonatal ICU care is well available and those who have not yet completed a full course of corticosteroids. And if glycolysis is employed, then the drug of choice may be, depending on the history of APH, should have fewest internal cardiovascular side effects, and the calcium antagonist nifedipine has been associated with cases of internal hypotension and is probably best avoided. Should the woman, should the antenatal care of the woman be altered following antepartum hemorrhage? If the placenta is diagnosed following APH, the placental abruption or unexplained APH, the pregnancy should be reclassified as high risk and antenatal care should be consultant-led. Fetal ultrasound for fetal growth should be performed. There is increased risk of oligohydramnios, premature rupture of membrane, fetal growth restrictions, preterm labor, cesarean delivery. And the author concluded that women who have experienced APS should have increased fetal surveillance throughout the pregnancy. In cases of labor and delivery, when women when should women with APS be delivered and what mode of delivery should be employed in women whose pregnancies have been complicated by APH? If fetal death is diagnosed, vaginal birth is recommended mode of delivery for most women, provided the maternal condition is satisfactory, but cesarean section may be considered for some. If the fetus is considered is compromised, a cesarean section is the appropriate method of delivery with concurrent resuscitation of the mother.